retrospective cohort of IBD and Pyoderma Gangrenosum patients over 2 decades, where we investigated mainly the demographics, the pyoderma location, first-line therapies, and biologic outcomes of patients treated with topical and systemic steroids as well as biologics. My name is Laura Keck. I am a third-year internal medicine resident, and title of my project is Precision Inflammatory Bowel Disease Medications, Efficacy in Pyoderma Gangrenosum. So the main takeaway message of this article is that while biologic therapies, especially anti-TNF agents like infliximab and adalimumab, are highly effective for treating Pyoderma gangrenosum associated with IBD, they are still not being used as first line in clinical practice. Most of our patients in this 2-decade cohort were initially treated with topical or systemic steroids, despite the accumulating evidence supporting the superior efficacy of biologics. More specifically, we had 192 patients, and we found that the main age of diagnosis was around 44.7 years. More than half were female and had Crohn's disease. The most common location was peristomal pyoderma, with 48.9% of patients who had pyoderma at this location, and was most commonly associated with ileostomy or colostomy. We found that the majority of patients were treated with topical or systemic steroids, but patients who were treated with biologics first line had 100% resolution. Our results suggest a gap between evolving evidence and real-world treatment patterns for PG-IBD. So how this finding relates to clinical practice is that it underscores a practice gap in the management of PG-IBD. I would say clinicians may rely initially on systemic steroids due to accessibility and historical precedent, but this may delay optimal healing for patients. The data, in fact, supports that biologic therapies achieve higher resolution rates and should be considered earlier in the treatment course. It is also important to recognize peristomal Pyoderma gangrenosum as a frequent complication of stoma creation and is also clinically important, as it calls for heightened surveillance and early intervention in post-ileostomy and colostomy patients, as well as an opportunity to intervene earlier on with biologics. Our findings are important for patients because they show that patients could have faster and more complete healing when biologics are initiated early for Pyoderma gangrenosum that's associated with IBD. Also, if we use biologics early on, we can reduce the reliance of corticosteroids, and this could lead to fewer skin and systemic side effects, which results in improved quality of life. In addition to that, patients with stomas, especially ileostomies, need to be aware that they may have an elevated risk of peristomal Pyoderma gangrenosum with their stoma. So this is important from an educational perspective for patients. And ultimately, this research promotes a shift towards more personalized, evidence-based care using targeted IBD biologics for the extra-intestinal manifestations like IBD. Going forward, I would say the next step of this research would possibly be to conduct prospective multi-center studies that compare different first-line biologics versus traditional corticosteroid-based regimens for PG-IBD. These projects could evaluate things like time to healing, recurrence rates, and impact on underlying IBD activity, as well as exploring the pathophysiologic mechanisms like pathergy with the peristomal pyoderma development. And then finally, research could include incorporating newer agents such as upadacitinib and risankizumab, which were rarely used during our study period, but now play a much larger role in the biologic era. So in summary, going forward, there may be future studies available for how we can standardize treatment algorithms for PG-IBD patients and optimize outcomes.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.